Now, we're very fortunate to have Associate Professor Henry Woo here this evening. He is a great supporter of this support group and a whole lot of other support groups, and PCFA generally, and he's a terrific urologist colleague of ours. So tonight, without any further ado, thank you, Henry.
Yeah, thank you very much for the kind introduction, David. Yes, I think I've been overseas almost every month this year to some conference or another. So at the moment, I don't quite know where I am. I'm about to go to Manchester in a couple of weeks.
Yeah, well, we're just getting ready with the weather for you, sir. Although it's good weather over there tonight.
Now, I have to say the weather in San Diego it was glorious weather at the time, and you know, it was another memorable conference. For those who aren't aware, the American Urological Association is the peak urological body in the United States. Some would argue that it is the peak body internationally, and it certainly has a huge international membership apart from its own US membership. It is the largest international conference in the urological calendar. It is also arguably the most prestigious. The Europeans are now staking claim that theirs is perhaps more prestigious, but historically the American meeting has been the meeting where, if you want to find out the very latest as to what is going on in prostate cancer, or if you've got something to say from a research perspective, that is where you go. Approximately in the vicinity of anywhere, depending on the given year, somewhere in the vicinity of 15,000 to 16,000 delegates will register for the meeting, and of those, about half of those are actually urologists. The other half are members of the trade, members of support groups, and others who have a vested interest in the area of urology. So as you can see, it's quite a multidisciplinary type of meeting, and it's the meeting where if you want to know something new about what's going on in urology, that's where you go. Now, the thing which makes this particular meeting a standout meeting is the fact that 3 brand new prostate cancer guidelines were released, and these guidelines form the basis for by which other organisations look towards formulating their own policies about prostate cancer. Now, the first of these was the detection of prostate cancer, and that's simply a rebadged, guideline document, whereas previously it's been called, for example, the Early Detection of Prostate Cancer, or PSA guidelines, and so forth. But essentially it's a set of guidelines regarding the detection of early prostate cancer. A new guideline is one for castration-resistant prostate cancer, and that's for prostate cancer that is no longer responsive to conventional so-called hormone therapy. And the reason why this is it's quite a good thing that we've now got this new guideline, because it I guess what it does, it recognises the fact that if your prostate cancer is failing androgen deprivation therapy, it's not necessarily the end of the line. You've probably been, for those of you who've been attending these meetings regularly, you've been hearing about how all of these new drugs are gradually finding their way onto the market. And so it's a very new ball game, you could say, where there are so many new treatments that we do need guidelines to help us know where these new treatments fit into the management schema. The other one is in regards to radiation treatment after somebody's undergone a radical prostatectomy, and that's a very brand new guideline. So it's very significant that we have 2 brand new guidelines here, and a significant update with the detection of prostate cancer guidelines, which have certainly caused a lot of controversy. How many of you are aware of the basic gist of this new guideline for early prostate cancer? David and Pam, obviously. All right, well, so David and Pam haven't stolen my thunder. All right, so with this early detection of prostate cancer guideline, what it tries to do, it attempts to address, early detection for the purposes of reducing prostate cancer mortality, with the intended user being the urologist. So these guidelines were created with the idea that the person who's going to be utilising the guideline is actually the urologist, but in reality, These guidelines are made freely available on the web, so urologists are not going to be the only individuals who will see these guidelines. The guidelines do not make a distinction between the terms early detection and screening, because they believe that both of these imply detection of a disease, of prostate cancer, at an early pre-symptomatic stage when men have no reason to seek medical care. The other thing is that it's very important to recognise that these guidelines do not address the detection of prostate cancer in symptomatic men. So if a man's got symptoms due to prostate cancer, these guidelines are not relevant. Those men, obviously, for example, if your man's got bone pain due to prostate cancer, it is logical that that man should be investigated and diagnosed and treated appropriately. Just to give you an idea of how the typical methodology involved in putting together these types of guidelines is that they assemble commission a group of expert urologists from the United States. They're always local urologists, and these urologists are all household names in our field. And what they've done is they've gone through a very comprehensive literature search. They've looked up all the articles, all the research articles that were published between 1995 and 2013. Now you might ask, well, what about the older articles? But the thing is that a lot of the very old articles didn't necessarily have PSA as a screening tool available. And there's also been shifts in the way in which we pathologically assess prostate cancer. So really, we had to use more recent literature from 1995 onwards to have some appropriate relevance to what we have today. Now, these publications were used to inform, create various statements in the guidelines, and they talk about things called the standards, recommendations and options. So after each of these so-called statements they make, they will advise whether it's actually a standard of care or whether it's a recommendation that urologists carry out a certain particular pattern of management, or whether it's an optional thing. And when they make this recommendation of whether it's a standard of care or recommendation, for example, they indicate the strength of the evidence that was used to make that statement. For example, a evidence rating of A means that there's a high level of evidence in the literature, B is moderate, and C is low. I know this sounds a little bit boring, but it's an important preamble to assist you in understanding, what each of these, what the terminology actually means when we see these guideline statements. So when we talk about a standard, that's a directive. The definition is a directive statement that an action should, and in brackets benefits outweigh the risks burdens, or should not be taken based on high level either grade A or B evidence. A recommendation is slightly softer than a standard. It's a directive statement that an action should or should not be taken on the basis of grade C evidence. An option, as the term implies, it's optional. It's a non-directive statement that leaves the decision regarding an action up to the individual clinician and patient, because the balance between the benefits and the risk/burdens appear equal or appears uncertain based on A, B or C evidence that is available. There's another couple of options which sort of fall generally below that, and one is called the clinical principle, and this is kind of like a grandfathered in type of view on how things should be managed, and it's just from general experience from urologists who have passed on their wisdom from one to another. And it's a statement about a component of clinical care that is widely agreed upon by urologists or other clinicians, for which there may or may not be evidence in the medical literature. And an expert opinion is where a statement is achieved by a consensus of, say, an expert panel that is based on the members' clinical training, experience, knowledge and judgment for which there is no evidence. So it's just a bunch of, wise urologists who try to reach some sort of consensus to help guide us when we don't actually have clinical trials to show us the way. All right, this is where it gets very controversial now when we look at the core guideline statements that came out of the prostate cancer detection guidelines. And these, of course, a great deal of angst within the profession and also amongst stakeholders in prostate cancer. Now, the first guideline statement is the panel recommends against PSA screening in men aged under 40 years of age. Okay, that's probably reasonable, because when you look at it, there are very, very few men aged under the age of 40 who actually are diagnosed with prostate cancer, and therefore, if you were to screen, you'd have to screen an extraordinarily high number of men just to pick up one cancer. Now, the other thing is you've got to remember these guidelines deal with the person who's got average risk, not the person who's got high risk. So therefore, if you've got a man who's 35 years of age and he's had, two older brothers have had prostate cancer, his father's had prostate cancer, it's also his mother's had breast cancer, and a couple of her sisters had breast cancer, and you can see this awful pattern of cancer, then quite obviously that man does not fit into this guideline statement. It's not intended to capture those. And a lot of people jump to conclusions. Hang on a sec, what about this anecdotal situation? And I think that's probably a reasonable thing to say. The second guideline statement, this is probably the most controversial of the lot, is the panel does not recommend routine screening in men between the ages of 40 to 54 years at average risk. Again, emphasise the word average risk. We're not talking about the high risks, for example, like African Americans and those with strong family histories of prostate cancer. However, the recommendation is made on the basis of evidence strength grade C. So it's a big call to make on what we call low-level evidence. Remember, grade C is low-level evidence, to actually say don't recommend routine screening. And one of the big problems with that is that it does fly in the face of a lot of evidence which shows that a baseline PSA can be predictive of how a man will go in the long term. For example, shortly after this statement, this set of guidelines was put together, there was a very interesting study which was just published from a Swedish population. It's called the Malmo study, which worked out that a baseline PSA in a man below the age of 40 was predictive of 50% of the prostate cancer deaths 15 years later. So imagine that from, a very early baseline PSA could predict in a significant number of men as to who was going to die from prostate cancer in years to come. Those involved in the panel discussion actually did admit that they had not included that study, and certainly I think that if they were to review these guidelines, they would include that information. The third guideline statement was, and you can see the ages are going up because they looked at each age group, the panel strongly recommends shared decision making for men aged 55 to 69 years of age who are considering PSA screening and proceeding based on a man's values and preferences. And they say this is a standard of care, so that's the highest level of recommendation, and the evidence strength is on grade B, which is, I guess, moderate level of evidence. The qualifying statements are that for men aged between 55 to 69 years of age, the panel recognises that the decision to undergo PSA screening involves weighing up the benefits of preventing prostate cancer mortality in one man for every 1,000 men screened over a decade against the known potential harms associated with screening and treatment. And for this reason, they came to the conclusion that the greatest benefit of screening appears to be in men aged between 55 to 69. All right, the fourth guideline statement: to reduce the harms of screening, a routine screening interval of 2 years or more may be preferred over annual screening in those men who have participated in shared decision-making and decided on screening. As compared to annual screening, it is expected that screening intervals of 2 years preserve the majority of benefits and reduce overdiagnosis and false positives. And I think this is something which most of the profession does agree with. But again, you've got to remember we're talking about average risk patients. So if somebody already is riding with a highish PSA to begin with, or one which is, close to being abnormal, they're the men who you probably will monitor a little closer, maybe on a yearly basis. But if you've got a man who's got a very low PSA, particularly PSA blood test levels, which are below the median PSA for their age group, those men there, you could make a very strong argument that you could actually not test their PSA again for even 5 to 10 years afterwards. In fact, with the Malmo study from Sweden, which I mentioned before, it was worked out that approximately half of the men, they only needed 3 PSA blood tests for their entire lifetime was sufficient to ensure that the vast majority of those men would not miss out on being diagnosed with a clinically relevant prostate cancer. So we're starting to recognise that, yes, for a lot of men, they don't quite need yearly testing. And it just comes down to us triaging these men appropriately. Guideline Statement number 5. The panel does not recommend routine PSA screening in men aged over 70 years or any man with a less than 10 to 15 year life expectancy. And the recommendation, it's a recommendation, and the evidence strength is grade C. Now, the other thing, they do have a little caveat there, which is some men over the age of 70 years who are in excellent health may benefit from prostate cancer screening. And we all know that because not every man is in perfect health at the age of 70, whereas you sometimes get men. I once had a man who was 78 years of age, and he did something like about 100 push-ups every day, and so I can't remember how many chin-ups he did. He was extraordinarily fit. He had a better six-pack than I've ever had in my entire life. All right, when it comes to making a decision, the panel goes on to try to qualify how we should perhaps think about how we counsel our men when making a decision about PSA testing. And that was in the guideline statement regarding the men who are aged between 55 to 69. So it is recommended that we should consider the risk of dying from disease versus the risk of dying from other causes. It should be stated that the screening tests are imperfect, and the performance of a test is often based upon the cut-off threshold, and there is some conjecture as to what PSA level is abnormal. Because you may have seen how in some countries or some hospital units will recommend that the PSA cut-off should be 2.5. You think, what? Or the PSA cut-off should be 3 or 4. So there is, or should it be age reference ranges? So there is quite a lot of disagreement, because obviously the lower that you set the PSA threshold, the more, I guess, false positives that you're going to end up with. You get all these men with so-called abnormal PSAs have actually got nothing wrong with them. And we also have to discuss the risks of biopsy and treatment. So let's look at the first one. The risk of dying from prostate cancer is about 3% over a lifetime on average. Now, when we look at data from 1977 to 2005, the lifetime risk of being diagnosed with prostate cancer rose 2.3-fold from 7.3% to 17%. And during this same period, the lifetime risk of death from this disease decreased by 20%, from 3% to 2.4%. So I guess that it makes a lot of sense in that there is a lot more early detection going on, because between 1977 and 2005, obviously, the PSA blood test became available, which then empowered men to have the ability to have their prostate cancer diagnosed. It also implies that a lot of these men were diagnosed with cancer that didn't actually need treatment. And there is a modest drop in the prostate cancer mortality, and we've seen this across, I guess, population data in most westernised countries, where you're starting to see with the increased use of the PSA blood test, so we're actually seeing a declining mortality. And I think that over time, that's we'll know a little bit more as to whether this is an artefact or a very real phenomenon. We'll move on to the next one. Second point about the fact that no screening test is perfect. Some tests, like digital rectal examination, are not particularly sensitive and certainly can miss a lot of early prostate cancers. It's actually quite reasonable for picking up the very, picking up locally advanced cancers, but to be honest with you, I don't even think DRE really needs to be done every year. I think that if you've got a good baseline DRE, and if the PSA is stable, the digital rectal examination does not have to be done quite as frequently as has been historically stated. And there's a lot of evidence to support that. Now, in terms of the performance of a screening test, I mentioned to you before how the cutoff can make a difference. And as I said before, the low cutoffs, when you're getting down to 2.5, you can end up with a lot of false positive results. There's increasing, opinion that perhaps the cutoff of 3 nanograms per mil, as from the major European prostate cancer screening studies, may well be the optimal cutoff. But again, there is really we still have a lot of conjecture as to what is the ideal cutoff. About prostate biopsies and treatments targeting localised prostate cancer carry risks. Now, the big thing is that with the prostate biopsies, in that we're faced with this new epidemic, and that is these multi-resistant bacteria, which are becoming a huge problem. And most of these multi-resistant bacteria are actually coming from China and India, where there's a lot of antibiotics are used in primary industry. And what that's actually doing, it's breeding out superbugs. There was a very interesting study where they actually tested puddles of water in New Delhi, and they discovered that the vast majority of these puddles contained E. coli, which is one of the bacteria we find in our gut, that was multiply resistant. In other words, we also call these extended spectrum beta-lactamase inhibiting bacteria, or ESBL. That's what that mouthful is often referred to. But these bugs are quite serious, and they're actually resistant to the vast majority of the antibiotics we have available. And the only antibiotics that really work against them are very restricted antibiotics available in major hospitals. So it's a very serious problem, and which makes us, which really has us thinking very seriously about, if we have to do a biopsy, we've got to be very careful about our case selection. The other thing about the risks of carrying out investigations is that we know that a lot of these men we diagnose with prostate cancer won't actually benefit from that having that diagnosed. Well, you can look at another way in that how do we know if this cancer is going to be one that is going to behave more like a tiger rather than a pussycat if we don't have histology or some sort of pathological confirmation of what type of cancer it is? So that's an argument which is not always considered. All right, so that's, I guess, summarises the new early detection of prostate cancer guidelines, and I'm sure you'll all agree that there are some controversial statements in there, but also there is actually a movement by the AUA towards some sensible middle ground, and particularly with regard to, I guess, recognising that not all men die from prostate cancer, and that there is an overdiagnosis problem and perhaps an overtreatment problem as well. Right, this I found particularly interesting was the new castration-resistant prostate cancer guidelines, and this is the first time that these have come out from this type of statements come out from the American Urological Association. So it is quite a landmark document, and they have approached this in a slightly different way to which most guidelines approach, where instead of just running through all the facts and coming up with various statements, what they've done is they've actually defined 6 index patients. That is, 6 typical clinical scenarios we see for men with castration-resistant prostate cancer. Now, just to recap, a man who's got castration-resistant prostate cancer is the man who's already gone on so-called hormone therapy, usually injections. And after being controlled, the cancer is progressing in spite of being on that treatment. So it is a treatment for advanced prostate cancer. Now, the 6 index patients are, firstly, the man who's asymptomatic and he's got non-metastatic castration-resistant prostate cancer. So this makes up probably about, we're starting to see an increasing number of men in this particular situation. Probably somewhere between 10 to 20% of men with castration-resistant prostate cancer don't actually have detectable signs of spread on scanning. Now remember, it doesn't mean that, when we say non-metastatic, it doesn't mean that these men don't have metastases. It just simply means that the scans that we have available lack the resolution to identify any metastatic disease that might be present. Right, the other 5 patients in this whole scenario are the asymptomatic men, so they've got no symptoms, and they're minimally symptomatic, and they've got the little m that stands for metastatic. They've got objective signs of spread elsewhere in the body, but they've never had chemotherapy in the past. The next index patient is a man. Now, the next 4 index patients are all symptomatic. They've all got metastatic prostate cancer. But firstly, we've got they're then sort of subdivided into either having good performance status or poor performance status. So basically means how sick they are. And they've also subdivided into whether they've had so-called docetaxel chemotherapy. That's Taxotere. I'm not sure if that's the main chemo. That's been the mainstay of chemotherapy for men with advanced prostate cancer. So they make up the other index patients. All right. Right, the index patient number 1. This is the man, remember, who's got no detectable metastases and is asymptomatic. We also call this M0 disease. That's when you hear clinicians talking about, oh, the man who's got M0 disease, they generally mean the castration-resistant prostate cancer patient with no signs of spread. In a way, that's quite a good thing to be in that place, but also the disadvantage of being in that space is that there's actually no specific treatment funded treatment, I should say, that we can actually offer these men. So these men, because they haven't got signs of spread, they're not eligible for any other treatment. So they're in this holding pattern, just knowing that at some stage they're going to develop visible signs of spread. And you feel a little bit helpless in that situation when you know something's going to go wrong, but you can't do anything about it. And this is why there's a strong call for clinical trials for men in that space. So it's about 10 to 20% of men who, when they are first diagnosed with castration-resistant prostate cancer, fall into that group. And I find that a lot of those men can fall through the cracks a little bit in our care. So with that man, with that particular index patient, clinicians should recommend observation with continued androgen deprivation therapy, and the recommendation is based on fairly low evidence. So it's a recommendation in spite of the non-low evidence. And the reason why it's a recommendation is because there is no other care that we can, there are no clinical trials to tell us what we can do with those men while they're in their holding pattern. Guideline statement number 2 for this patient is clinicians may offer treatment with first-generation anti-androgens. They're drugs, the main drug used in Australia is bicalutamide, which is also known as Cosudix. And they say all first-generation androgen synthesis inhibitors, in other words, ketoconazole, we don't tend to use that in Australia at all. Actually, very, very few, even medical oncologists will use ketoconazole because it does have a lot of side effects. And these are for the men, they say, who are unwilling to accept observation. As I said before, a lot of these men, they find themselves feeling quite helpless because there is no specific treatment that is approved for treating men in that space. Again, it's evidence level grade C, and it's an option there. And thirdly, clinicians should not offer systemic chemotherapy or immunotherapy. That's the Provenge stuff, the vaccine you've heard about. That's what we mean by immunotherapy. For men with non-metastatic prostate cancer outside the context of a clinical trial. Because at the moment there is no evidence that giving them chemotherapy or the vaccine will actually positively benefit these men. What those treatments could do is actually make these men quite sick, because quite often these men are actually they feel absolutely great. They feel well. And all a treatment can do really to them is make the quality of life worse as a result of side effects. Index patient number 2. Okay, so these are again asymptomatic men, but they have got evidence of metastatic disease, and the cancer is progressing in spite of androgen deprivation therapy. Now for these ones, the first guideline statement is clinicians should offer either abiraterone with prednisone, because they go together, docetaxel, which is the Taxotere chemotherapy that's commonly used in this country, or the vaccine, Provenge. to patients with asymptomatic or minimally symptomatic metastatic castration-resistant prostate cancer with good performance status and no prior docetaxel chemotherapy. And there's quite high level evidence, particularly with the Zytiga or abiraterone, and to a lesser degree because the studies were not as robust as the abiraterone study, the Zytiga study. But the main reason with docetaxel and sibuleucel is that those patients were a lot sicker than this group we're talking about. Statement number 5, clinicians may offer first-generation anti-androgen therapy, ketoconazole plus steroid or observation to patients with asymptomatic or minimally symptomatic metastatic castration-resistant prostate cancer with good performance status who do not want or cannot have one of the standard therapies. So basically, when we talk about first-generation anti-androgen therapy, we're talking about the drugs such as Cosudix. So you can add that to their LHRH agonist or to, I guess, in a way, their treatment by having had a bilateral orchidectomy. All right, to the third index patient, and this patient here is symptomatic. They've got good performance status, and they've not had chemotherapy in the past. So that's what this index patient number 3 is. So it's actually quite a good way of doing it because all of these 6 patient groups are every man for the purpose. That is carbazitaxel, which is the sort of the older brother or younger brother of taxotere, and that's considered to be next line chemotherapy when docetaxel fails. Statement number 9 is clinicians should not offer treatment with either estramustine or vaccines to patients with symptomatic metastatic castration-resistant prostate cancer with good performance status and no prior docetaxel chemotherapy. Right, the index patient number 4. So these patients, they're symptomatic, they've got poor performance status, and they've not yet had chemotherapy. So basically they say that clinicians may offer treatment with abiraterone, so that's quite an appropriate group. In fact, the abiraterone is actually tolerated very well. It's actually, considering that it's a drug used at such a late stage of prostate cancer, it's amazing how relatively few side effects it has compared to any other drug used to treat cancer. And it really is, a very exciting drug. I think it's a real game-changing drug. And I'm sure the PCVA is doing a great deal of work to try to make this drug accessible to people. It's going to make a huge difference. Clinicians may offer treatment with ketoconazole, again, not so relevant, or radionuclide therapy. That's another particular drug which I'll talk about later, which is not yet available in Australia. So I guess as far as Statement 11 is concerned, that's not relevant for Australia at this point in time. Number 12, clinicians may offer docetaxel or mitoxantrone chemotherapy for patients who are symptomatic with metastatic castration-resistant prostate cancer with poor performance status and no prior docetaxel chemotherapy. In select cases, specifically when the performance status is not directly related to the cancer. And that's based on expert opinion. So what they're worried about is that when you give chemotherapy to somebody who has already got one foot in the grave, basically, when they're too sick to have chemotherapy, you've got to think twice. And likewise, if you are that sick, you probably should not give the vaccine therapy as well, because that actually can make men quite sick. Now, the index patient number 5, the clinicians should offer treatment with abiraterone and prednisone or carbazitaxel, which is that other chemotherapy that follows docetaxel, or the new drug called enzalutamide. Enzalutamide is also known as MDV-3100. It's only just relatively recently been given a generic name of enzalutamide, and I'm still trying to get used to calling it that because I still call it MDV-3100. But anyway, to patients with metastatic castration-resistant prostate cancer. Now we've gone back to good performance status, and these men have already failed the conventional docetaxel chemotherapy. Now you notice how the enzalutamide only appears now, and the reason is because the study results that use that drug prior to conventional chemotherapy have not yet been completed. Ketoconazole is not so relevant here, this is the other thing. Clinicians may offer retreatment with docetaxel. So if they've already found that there is reason that there are situations where you can actually try it again. Now moving on to index patient number 6, and clinicians should offer palliative care to patients with metastatic prostate cancer with poor performance status and who have already received docetaxel chemotherapy in the past. Most of these patients obviously are not doing well at all, and the options are limited. However, I think it's not unreasonable for selected patients. They could try treatment with abiraterone or enzalutamide because these treatments are very well tolerated. They're tablets. They're taken sort of as a daily dose. So that's why these particular drugs, being well tolerated, even if you're quite sick, you may actually be able to tolerate them very well. And they say that clinicians should not offer systemic chemotherapy or immunotherapy to patients with poor performance status who've received prior docetaxel chemotherapy. Again, both of these statements are expert opinion. And a final comment is regarding bone health. Clinicians should offer preventative treatment, for example, supplemental calcium and vitamin D for fractures and skeletal-related events for these patients. And the other thing in relation to bone health, clinicians may choose either denosumab, which we can't currently use for men in Australia, and I'll explain to you a little bit about that in a moment, and zoledronic acid when selecting a preventative treatment for skeletal-related events. Denosumab has been approved overseas, but not in Australia. There is an issue we've got where it is available as a treatment for women with bone health issues, but not for men. Another thing which is holding back its approval is the fact that in one of the studies using this drug called denosumab, they noticed that seemingly more men were getting cataracts. Now, cataracts occur very commonly in the ageing male, so it was only one study out of many. And it doesn't really make a great deal of sense that why should men get cataracts from this medication and not women? So there is a possibility it just might be an artefact. And for that reason, the FDA has mandated a study be carried out just to prove that cataracts don't occur in any greater frequency. So until that study comes through, then it's very much off-label if we give it to men. But the thing is that the results from the studies of denosumab appear to mirror those for zoledronic acid. And you can take a guess which drug has got the most side effects. To give you an idea, zoledronic acid is given as an infusion, whereas denosumab is given as a subcutaneous injection every 6 months. It's another great drug that's going to make a difference to the care of advanced prostate cancer. So just you've seen a number of these drugs which we briefly touched on were Zytiga or abiraterone, enzalutamide, denosumab, and another drug called alpha-radin, which is that radioisotope. I didn't really talk about that much, but it's not currently available in Australia. And all of these drugs, I believe, are going to have a place, and they are going to make a huge difference. These days, I'm very careful about giving prognostic indicators to my men with advanced prostate cancer as to how long they're going to live. And to be honest with you, I don't really know, because I just don't know how much impact these drugs are going to have. I think it'd be a bit brave to be too predictive when we've got all these new treatments coming through. Now, this is another new set of guidelines. There is radiation treatment after radical prostatectomy. And the first guideline statement is patients who are considered for management of localised prostate cancer, radical prostatectomy, should be informed of the potential for adverse findings. So in other words, you've got to men have to be warned that there's a possibility that the cancer may prove to be more than what was advertised by the biopsies, and therefore radiation treatment may be necessary. So they need to have that sort of little warning up, that it might be necessary. It doesn't mean it's necessarily a bad thing, but it just means that there's a little bit more of it. There's more of a circuitous path to perhaps get the desired outcome. Now, this is a relatively controversial statement here, and they've written down here clinical principle, which means that it's not based on the highest level of evidence, is that patients have got adverse pathological findings, and these on their radical prostatectomy specimens, such as seminal vesicle invasion or a positive surgical margin or extraprostatic extension, should be informed that adjuvant radiotherapy, which means radiotherapy within, say, 4 to 6 months after the surgery, compared to surgery alone, does reduce the risk of cancer recurrence. And I think that's pretty clear, but we've got to weigh that up against the fact that a lot of those men may end up getting radiotherapy all for nothing. Physicians should offer adjuvant radiotherapy to patients with adverse pathological findings at radical prostatectomy, including seminal vesicle invasion, positive surgical margins, or extraprostatic extension, because of demonstrated reductions in biochemical recurrence, local recurrence, and clinical progression. So, again, this is controversial because it's not routinely offered for men with adverse findings. It's even though they say the evidence strength is grade A, the patients are often selected, relatively highly selected in those studies, and not everybody falls into I guess, the fit for the patients who are in those studies. So that is quite a controversial statement made. Statement number 4, patients should be informed that the development of PSA recurrence after surgery is associated with a higher risk of the development of metastatic prostate cancer or death from the disease. And clinicians should define biochemical recurrence as a detectable rising PSA value after surgery. So the definition is when the PSA hits greater than 0.2, that's when we say yes, where there is definitely clinically relevant cancer recurrence. If the level's below that level, a lot of times, yes, that does mean there's cancer recurrence, but for all intents and purposes, it may not be clinically relevant. It may have no impact upon your ultimate survival. And here's a number of other statements. We'll go through these very quickly. Restaging evaluation with a PSA recurrence may be considered. That is getting bone scans and CAT scans. Physicians should offer salvage radiotherapy to PSA or local recurrence after radical prostatectomy in when there is no evidence of distant metastatic disease on scans. Patients should be informed that the effectiveness of radiotherapy for PSA recurrence is greatest when given at lower levels of PSA. So therefore, after radical prostatectomy, once your PSA is hit 5, you're already too late. If it's hit 2, we used to think that it's got to be done before they hit 5. Then we started to say it's got to be done before we hit 2. Then we started saying it's got to be done before we hit 1. And now most of us believe that if you're going to be serious, you probably ought to try to get in there before the PSA hits 0.5. So there's been moving downwards. And patients should be informed of the possible short-term and long-term urinary, bowel and sexual side effects of radiotherapy following radical prostatectomy. All right, that completes the 3 guidelines, but there's one other thing which I'll do in the last couple of minutes if I can, but something that was very different about this year's AUA that made it stand out more than any other American Urological Association meeting in the past, and that was the social media at the AUA. Now, I'm not sure how many of you have heard of Twitter, and when you think of Twitter, you think of, Britney Spears, Kim Kardashian, and those likes, and you think, no, I don't want to bar it. You hear Shane Warne's, done some more sexting on Twitter or something like that, and footballers doing stupid things. But the thing is that the whole experience on this micro-blogging platform is dependent on who you follow and what your aims are with that technology. And with Twitter, you can actually have discussions with your colleagues, and Twitter has now become a huge thing at conferences. We call it conference tweeting. So what happens is that when people are sitting in a session, they hear a great statement made, they'll often say, wow, prostate cancer deaths reduced by 50%, and they'll tweet that, and they'll quote by Walsh, and then that will go out. And lots of people who weren't necessarily in that room will get to see it, and they'll go, whoa, what's this? And you might actually send a picture of the slide which is associated with it. Well, this shows you the what actually happened during the AUA meeting, and you can see that this graph here demonstrate the number of tweets that were sent out. And you can see here that at some stages of the meeting, obviously this is at night, overnight, people got a bit quiet, but not completely quiet. Some people were out fairly late, it's very clear, because it didn't go to zero. But you can see at some stages, the tweets got over 750, say, for example, at some points in the day. So therefore, you had some periods of time when there may have been 750 tweets in the space of an hour, which is phenomenal. And the other thing is that you have all these various metrics. You can have people who get the most mentions, or people who've tweeted the most, or the people who've had the most impressions in terms of the reach from the base of their followers. And here I am sitting there, number 9 in the tweets and number 9 in the impressions. But this is the most impressive thing and it's a way in which information at these conferences are now reaching a much wider audience than ever before. Now, this, as I said, this meeting was a real standout, and this is the first time that tweeting at this conference has been to this scale. Now, you can see that there were 505 people were participating with the Twitter feed. And on average, it was 32 tweets per hour. But don't forget, that includes averaging it over the hours when we're meant to be asleep. So that's why for some hours you might have been up to 700. And so there were almost over 4,500 tweets. But look at this, the number of impressions. This is the number of Twitter lines, Twitter accounts that these tweets landed on. Over 6.7 million accounts. It's phenomenal, and the reach is phenomenal. And that's what we mean by the so-called, we talk about this exponential or viral, or multiplicative effect of Twitter, and it happens very quickly. So when news hits a meeting such as the AUA, like the new guidelines, now the information about saying not to screen men aged 40 to 55, that statement went out almost instantaneously from the moment it was announced. And I wouldn't be surprised if that had already hit in the vicinity of hundreds of thousands of accounts within 30 minutes. That's how quickly these things disseminate. And this is just a picture which summarises all the people who are sort of contributing. I wonder if I'm in there. Oh, here I am. I found myself. There we go, just there. And I could just see Declan Murphy there and Stacey Loeb, and anyway, there's a whole host of us there. And but it's really changing the whole face of conferences, and so you can now actually hear about what's going on in a meeting, but not actually be there. And I think it's quite exciting because we can actually get cutting-edge information almost immediately. Another very quick example of how it makes a big difference is when the you might have heard this study called the PIVOT study. Have you heard of that? It was a randomised controlled trial of prostate cancer treatment versus doing nothing and conservative management. And when that study was published online ahead of print by the New England Journal of Medicine, that was actually out there probably into hundreds of thousands of accounts within about 10, 15 minutes. And within 1 hour of it going online, just from the tweets, I knew everything I needed to know about that paper. It's phenomenal. And without even having to read the entire paper, because people were submitting their one-liners, 140 characters, which told us pretty much everything we need, key points about the paper. Urologists love Twitter because it's succinct, it's to the point, it cuts the rubbish. So it requires some clarity of thought to tweet well. All right then, so just something a little bit different was the last about the social media there, but otherwise you can see it was quite an eventful meeting simply on the basis of those guidelines that were presented. Thank you very much.
Thanks, Henry. Now, so has this changed the meaning of EuroTwit?
Yeah, it has. It has. This is changing the nature of the meeting forever.
Yeah.
And it's when we look at the use of Twitter in the meetings is actually growing exponentially. For example, with the European Association of Urology, which was only held a month earlier. Now that's always thought to be a meeting which is thought to be far more advanced in terms of I guess IT and technology. And when we saw that that meeting had, say, about 250, 300 participants and a Twitter reach of around about 2 or 3 million, we thought, wow, that's amazing. But the AUA almost doubled that. And just in the space of 1 month, that's how quickly it's growing. So if you were to hold another major meeting, I think within a couple of months, we'd probably double all those figures. That's how quickly it's growing.
No, it is amazing. The people at PCFA, led by Dr. Anthony Lowe, our CEO, he's a great Twitter, isn't he?
He is.
And some of our senior people who are more used to it than people like me, they love it. And it is, like Declan and all these people are all the people that we deal with over the course of a year. So it's very encouraging. Henry, that was a really good summary of the AUA meeting and those guidelines. I just want to let people know what's happening in Australia. Over there, that's a medical association, a professional medical organisation for urologists. And what we're doing here in Australia is that we are working with the NHMRC, leading a group of people that covers urologists, radiation oncologists, medical oncologists, GPs, epidemiologists, cancer councils, etc. And that work dovetails into the work that the PCFA and the cancer councils, the PCFA and the Cancer Council Australia are doing with an expert panel. So there's 2 expert panels in Australia that dovetail into one another who are working on evidence-based clinical guidelines for Australia. And next year we'll be able to have that, because one of the really difficult things with PSA screening or testing, whatever you want to call it, is the different opinions of a urologist, different opinions of a GP, the epidemiologist. So we're very unique here in Australia. We can actually pull all these medical professional organisations together, put them all in the one tent. Everyone agrees that it's time to get clarity that's evidence-based to give people clinical guidelines. So that's this work that Henry has talked about will be fed into the process here in Australia on those 2 expert panels. So it's very good to hear that. Now, a question. Thank you.
Dual microphones. Thank you, Doctor, for your great summary. I saw no mention of the significance of the rate of change of PSA in early detection in your summary. Could you comment on that? And while I've got the floor, the program advertised that the good doctor was going to speak to us about robotic-assisted radical prostatectomy. I'd like to know where that stands in the program.
Okay.
Sure.
Well, he was, but like all medical professionals, they're calling the shots when they want to present. So that's Henry's been away, and this is his presentation. But I'm sure he can answer questions on where we're up to with radical prostatectomies as far as robotic assisted's concerned.
Yep. Okay, look, when it comes to how it all fits in, is that the person who has got the abnormal PSA velocity doesn't fall into the average patient, which is what these guidelines try to, try to give guidance on. So if you've got a person who has got it, it's still, the PSA velocity is still important. I guess that's the bottom line. And it's, we have to remember that, that these guidelines are based on the average patient. And I think once you've got a abnormal PSA velocity, you no longer become part of this guidance. As far as the, I apologise that I haven't presented on the robotic assisted radical prostatectomy, and I'll give you, it was actually intentional at the end of the day. The plan was to do just that, as I was planning to cover both what we've seen at the AUA and that. But as you know, the AUA was only a few weeks ago, and the AUA, these guidelines I thought was such a priority issue that I thought that that I had to make a choice. I couldn't cover both the guidelines and robotic radical prostatectomy in one talk. So I made a relatively late judgment call that if I have to discuss something, I think that the more important thing is what's happening in the space of these guidelines. I think with the robotic assisted radical prostatectomy, there actually is quite good information out there already, but there's still relatively little about the new guidelines. Very happy to come back again another time.
No,
to
so
talk about
you've invited yourself. What's that?
A whole lot of vacant dates.
Yes, we'll wait for the next one.
So I apologise for that. It was just it was a judgment call I made to prioritise.
No, that's good. Very good, Henry.
Sometimes you just don't know when you go to an AUA meeting. You just don't know what is going to be the king-hitting things that come out of that meeting.
Yeah, I'm right in saying, Pam, that we've got all those TBCs covered now, so in the next edition, but what we'll do is we'll get Henry to come back at one of our afternoon sessions if he can manage it.
Sure.
Okay. Up the back there, Pam.
Henry, just on a fairly specific thing, on the radiation guidelines, there was a recommendation there for where there was seminal vessel invasion,
Yes.
and also positive margins. What's the situation with a seminal vessel invasion but negative margin, or
Yeah, there has been I guess a number of publications which have suggested that there actually is benefit in treating men who have got positive seminal vesicles in spite of having negative surgical margins. Historically, we used to say there's no way we should give them radiotherapy because of the fact that because we thought that having seminal vesicle involvement meant that you must have a very high chance of having micrometastatic disease. But what we've learnt through subsequent trials is that, well, hang on a sec, if your cancer's got that capacity to go into the seminal vesicles, it also has the capacity to go into the local blood vessels and the local nerves, travel along the local nerves and actually jump across the margin. And we've recognised that some of those men do in fact do very well. So it does introduce this question as to maybe should we be offering all men with seminal vesicle involvement but with negative surgical margins radiotherapy. Now there's a lot of controversy in that because when we look at those studies, the overall benefit, yes, there is an overall benefit if you do give radiotherapy, but what those studies don't tell us reliably is the timing of radiotherapy. Now, whether you give the radiotherapy early, that is early after the surgery, or whether you give it as a salvage, that is not told by those studies. All we do know is that the overall sum of men who have the radiotherapy do better than those who do not. And that's why there is a very important study called the RAVE study, which actually randomises men between having early radiotherapy or later radiotherapy, or salvage radiotherapy. And that study is going to be very important because that's going to help guide us as to, in that particular scenario, as to whether we should simply watch them and just give the radiotherapy if the PSA starts to shift, or do we just get in there like we do with breast cancer and give them belt and braces? That's a very good question.
that was a RAVE
The RAVE study, that's
RAVE
right.
study. Thank you.
Another question? John?
As an elderly ex-researcher, I'm concerned about this business of working on tweets. When one presents at a conference, you are taking great care to present all the pros and cons. People know how many subjects you've got in the treatments, and the whole works is all well presented. Everybody can assess it. You take a mere 140 characters out of that and send it worldwide. Now, isn't there, to be honest, a potential for exaggeration or for misunderstanding?
Yes.
Because you are missing out on those things. I'm not so happy, really, about this. And it occurs in politics, it's occurring in everything now. I don't know that it's a good trend for solid, reliable information in our society.
Yeah.
Okay, just a comment.
No, I think it's a very
That's a
valid
fair comment.
It's a very fair comment. But what actually happens on Twitter, in a way, it's a kind of it's a self-moderating type of forum, where I'm much more likely to take notice of a tweet from, say, Associate Professor Matt Cooperberg from UCSF, rather than from a tweet from Britney Spears about prostate cancer. So credibility is everything. And so therefore the person who is actually making the tweet, people do examine that very carefully. And the other thing is there will be differences of opinion. And you you don't, if it's something controversial, you don't, common sense would dictate that you're not going to rely upon just one tweeted bit of information. You're going to look at the summation of it all. And what you do when you get the so-called tweet line, where you see all these tweets coming through on the topic that you're watching, and you get a general sense of what reality is and where exaggeration occurs. There is a bit of a skill in it. There's a skill in not only interpreting it, but there's also a skill in communicating it.
John, I must say, I subscribed to your view until recently, and as you know, we get to quite a number of these conferences, and we're with people like Henry and Declan Murphy and these characters, and it's a sort of a self regulatory thing, isn't it? Because if something's said that's not right, it soon gets corrected by an expert. So I'm between you and Henry. It'll take some getting used to, but
it does.
I can see these guys, and I watched through Anthony Lowe, the CEO of PCFA. He uses it to great effect.
He does. He uses when Anthony actually puts out a message. It actually, I guess the ability to get out a simple message. For example, you also want to make an announcement about some major finding prostate cancer. The ability to get it out with one tweet and have it land on so many people's account. You cannot imagine doing that with email or with a press release or even just getting up on the radio. I don't think anything comes close to the viral effect of social media. A lot of people are a little bit worried about how to bring this into their lives. But the reality is all our kids are growing up with it. To them, it's just, it's nothing special. They're sort of wondering why your old Luddites worrying about this. But the thing is that for a lot of people, certainly in my generation, are starting to recognise that you can either take it on board, accept it, or be taken into it kicking and screaming. I remember when email was first introduced to our society, and people saying, "There's no way I'm having an email. I want it faxed to me or sent by snail mail." And until one day the society said that no more mail, you're getting it by email. Suck it up, or not be in it. And everybody got email addresses, and now how many 15 years later or 20 years later, nobody complains about email. We accept it.
Yeah. No, it's a good one. Is there time for one last question? One last question. Yep. Thanks, Pat.
Just coming back, Henry, to the first question about the rate of change of PSA as opposed to the absolute level. Obviously you look at both, but is either one or other the most important in terms of, because I got the impression when I came to see you that the rate of change was really one of the things
my personal thoughts are that if there's nothing like having a PSA history, and if your PSA history does demonstrate a clinically significant rate of change, to me that takes precedence over the absolute level. So we sometimes see men, every PSA level may well be below the so-called reference range.
Yeah. The other thing was, I remember talking to you, you were doing some work to see if you could use semen as... did that ever get anywhere?
It sort of did, but didn't. And I'll explain. I'm very happy to explain that. It was shown to have some use, but it wasn't quite good enough, and it did need some tweaking. And what happened was the company that was developing the test realised that it was going to cost several $1 million more to develop the test, and they didn't want to put that money into it. Now, they unfortunately, this is the ugly side of research, is that they refused to give us permission to publish the ordinary but promising results because they didn't want anybody else getting the idea on how to take their IP and then make money out of it. So, unfortunately, that's But
it's still pending.
There is still potential in it. But the thing is that it requires a company that's prepared to invest that money into it. And really, to develop tests like that costs millions of dollars.
Tens
of millions of dollars.
Tens of millions
yes,
of dollars.
Indeed.
Okay, no last question. All right, well, it remains for me to say thank you on your behalf to Henry. He's always willing to come and talk to us, and this is very up-to-date information. And now you've got the context of the Australian situation too, so you should be much more knowledgeable on it. And it was a very good presentation, Henry.
Well,
We thank you very much.